Hi, today we're going to talk about tuberculosis. Please follow along in the PowerPoints and pay specific attention to the tables and figures that I have listed throughout. Real quickly, we'll discuss the objectives. We're going to review the patho and classification of tuberculosis, discuss the complications, manifestations, diagnostics, and the treatment, and also some of the nursing management required for folks that have TB. I'm going to pose a question to you. A client with primary TB infection can expect to develop which of the following conditions? A, an active TB within 2 weeks. B, active TB within 1 month. A fever that requires hospitalization. Or a positive skin test. Well, the answer is D, a positive skin test. This means that you probably have some TB germs in your body. Most people with a positive TB test have a latent TB infection. But to be sure, you have to go to the doctors and they will do some tests to determine if that is the case. So really, what is TB? Well, it's a bacteria that usually attacks the lungs, but it can attack other parts of the body as well. Lymph nodes, bones, joints, your brain, other organs. It's pretty nasty, but it can attack any part of your body. Statistically, on average, 1 person dies of TB every 15 seconds. That's a huge, huge amount of folks that we are losing due to TB. It is the leading cause of mortality in patients with HIV. And it's just not a disease of past impoverished countries. Granted, we don't really have the occurrence here in Front Range, and we're very lucky about that. But we do have individuals that have been traveling that return here, and that is how and why we are discussing it now, because you never know when you're going to be taking care of a patient with TB. More than 14 million people actually have TB in the U.S., and greater than half of them are foreign-born residents. Risk factors? Well, you can imagine homelessness is at the top of the list. Residents of inner-city neighborhoods, foreign-born persons, just like we mentioned, those that are living or working in healthcare institutions, so that includes us, okay? It includes nurses, it includes those residents that are living in long-term care, IV injecting drug users, those that are at the poverty level, have poor access to health care, those that are immunosuppressed, whether they are on long-term corticosteroids, have HIV and AIDS, that puts them at a very high increased risk. So what is TB really? What is multi-drug resistant TB? We already just said that it's basically a bacteria in the lungs and also other parts of the body, right? But what about multi-drug resistant TB? Basically, that is a variant of the original TB. And research shows that drug resistance is caused by incorrect prescribing, erratic supply of drugs, poor quality of drugs, and patient non-adherence. And as we get through this, you'll see that patient adherence is huge, and it's really easy to understand why patients do have a hard time adhering to the very strict, very regimented medications that are required when they are diagnosed with TB. Etiology and patho. Well, it's airborne, okay? It's huge air droplets. They can stay suspended in air for minutes to hours, and the transmission really requires close, frequent, or prolonged exposure. Like if you're standing next to somebody and they sneeze, breathe, talk, sing, cough, that is how those air particles are going to get into your body. It's not spread by touching, sharing utensils, kissing, or other physical contact. One interesting thing about TB, it has a hallmark of the infection. It's called a Ghon lesion, G-H-O-N lesion. Basically, it's calcified TB granuloma. And what happens is that once you're exposed to TB, your body forms this calcification that basically protects it. So once that gone lesion has been created, it's basically a defense mechanism, and it kind of tells the infection to back off and prevents any further spread. So at that point, the infection is stopped. So if you have a chest x-ray and you have a gone lesion, at one point in time you were exposed to TB. Let's talk about the classifications. There's 3 main classifications. Technically, you could have a TB exposure, so no infection, no symptoms, and a negative skin test. So at one point in time, you could have been exposed, but you didn't get it, okay? No symptoms and negative skin test. The second classification is a latent TB infection. Once again, no symptoms. It's not active. The difference here is that you do have a positive skin test. So for latent TB infection, you can have no symptoms, it's not active, there's no x-ray findings, no positive x-ray findings, you're not contagious, but you still have a positive skin test. Really important that you understand that. The final classification under TB disease, clinically active or clinically inactive. Clinically active, you have a positive skin test, a positive bacteria test, positive x-ray, and you are sick, super sick. Clinically inactive, you could possibly have had a previous episode. You have a positive skin test, negative bacteria, negative x-ray, and you have no symptoms whatsoever. And we'll go into these a little bit more specifically. There are certain conditions that increase the risk of the active disease once infected. So persons with HIV and AIDS, children under 5 years of age, those that are receiving any sort of immunosuppressive therapy, diabetes, chronic renal failure, leukemia, lymphoma, cancer, cigarette smokers, those that are medically underserved or low income. All of these factors increase the risk of getting an active disease once infected. What are the manifestations? Okay, patients with TB usually have one or more symptoms, and as I said, it can affect different parts of the body. Okay, so your symptoms would be varied. Just in general, you could have a dry cough, chills, low-grade fever, weight loss, appetite loss, fatigue, malaise, and night sweats, pretty significant night sweats. Acutely, high fever, chills, generalized flu-like symptoms, crackles, dyspnea. So as you can tell, you could have it and not really know it. You could have these very almost benign symptoms. The important thing to remember is that symptoms usually do not occur until 2 to 3 weeks after infection or active or after reactivation. So you could actually have TB and not know it for at least 2 to 3 weeks and be walking around and exposing the population. Specific manifestations of pulmonary TB disease, okay? Those are the ones that are specific to the lungs, of course. They usually do not develop until 2 to 3 weeks after the infection, which is what we just talked about. You could have a dry cough lasting more than 3 weeks, which usually becomes productive, chest pain, dyspnea, and like a bloody cough. Those are late symptoms. If you have extrapulmonary TB disease, basically it means that it has spread to different parts of the body. You could have TB in your spine, could cause you back pain. You could have TB in your lymph nodes, that could cause swelling in the neck. So symptoms are really based on where the TB has tried to call home. As you can tell, this just sort of reiterates the extrapulmonary TB. You've got a picture of a little one there with very severely enlarged lymph nodes. Obviously much larger than anything you would ever see with, say, strep throat. And then you have a lower extremity which has been affected as well. So let's compare latent infection versus an active disease process. A latent infection, you don't feel sick. You have no symptoms. You can't spread it. However, you're at risk for developing TB. Okay, like if you're one of those underserved populations like we talked about, okay, or if you have HIV or AIDS, you're more likely to develop TB with that, okay? Active disease, you feel really sick. You usually have one or more symptoms, and you may be able to spread the TB bacteria to the general population. So how do the doctors know that you have active TB? Well, they're going to put you through a bunch of different tests. They're going to put the patients through a bunch of different tests. They're going to have a very significant medical history exam, a physical exam, test for TB infection, which is also referred to as an IGRA, a chest x-ray, and then bacterial samples, so sputum and also samples from other parts of the body. You guys should be really familiar with this Manitou test, this TB skin test. You have to have it done so you can get into nursing school. Basically, they're injecting just a teeny tiny amount of the TB antigen into you, and they are reading those results in 48 to 72 hours after that administration to check to see if you have an induration. Okay, just so you know, just if you have a positive skin test doesn't mean that you have TB. Okay, positive result and positive exposure may not indicate TB present. Super important fact. The induration, which is basically a lump, is measured in millimeters, and that millimeters, the size of the millimeters is based on if you're positive for low risk individuals, moderate risk individuals, or high risk individuals. Obviously, the higher risk the individual, the smaller the induration has to be, would be to classify them as having TB, active TB. You don't need to know the numbers, just know that as folks that are of higher risk, they don't need to have a fairly large induration to have a positive reading. Let's talk about, let's see. Okay, IGRAs, what are they? They're the blood tests that measure the immune reactivity if someone does have TB, okay? The hard part, though, is that these blood tests cannot distinguish between latent and active disease. It's really just a screening tool, okay? You can think of it that way. What else are doctors going to be ordering to see if your patients possibly have TB? Well, they're going to order a chest x-ray. But once again, no diagnosis is solely on an x-ray because there's so many other disease processes that mimic the appearance of TB. But just know that they will order an x-ray. So what is the gold standard? How do you know if your patient has TB? Well, the sputum culture is the gold standard for diagnosing, okay? It's absolutely positively required. There's no way of getting around it. They need 3 consecutive specimens collected on different days. The culture itself can take up to 8 weeks. And then they also may examine samples from other suspected TB sites, okay? So let's just say they suspect that it has gone to the lymph nodes, okay? They're going to get some samples out of that. Don't forget, though, the sputum culture is the gold standard for diagnosing TB. So let's just assume the doctors say that you require latent treatment, that you have a positive TB. Most are treated outpatient. Unless they are super sick, they'll end up in the hospital. Patients could still be positive. They're infectious for 2 weeks after starting the therapy. So they're really going to limit the exposure, their exposure to anyone outside. Positive TB active, okay? That's where we're talking about the very significant treatment. It's consisting of several drugs. I understand it could be half of a dozen. Treating with several drugs is the most effective way of killing all of the bacteria and helps to prevent drug resistance. The rifampin, that is one that is usually the one that I have seen used the most. The important thing to remember here is that with TB medications, they are all very, very hard on the liver. They're hard on the entire body, but specifically hepatotoxic. Treatment-wise, you don't need to know these initial phases, the continuation or relapse. Just know that it's a very, very extensive treatment, and that if patients are not compliant with medications, they could it could reoccur. The disease could recur at a later point in time. Continuing with that, positive TB active treatment lasts for at least 6 to 9 months. It could even last longer if they have a multi-drug resistant one. If they stop taking the medication, it could continue to cause problems, and then it can reoccur as well. So as nurses, your job is to educate your patients on how long they will be needing to take this and what sorts of symptoms and side effects that will happen with this. TB drugs, there's tons of side effects. As I said, liver toxic, that is the one thing that you are really going to be watching as you're taking care of these patients. You're looking for specifically any symptoms that have any sort of liver involvement. And I know you guys know what those are, but we'll go over them in just a minute. They're going to be monitoring the liver labs very frequently, every 2 to 4 weeks. Requires total completion of the medication. You're going to educate your patients on alcohol use, because alcohol use increases hepatotoxicity. You're going to be monitoring signs for hepatitis, right? That's the yellowing of the eyes, yellowish skin, that kind of thing, okay? Side effects, they're not going to have an appetite, nauseous, vomiting, yellowish skin or eyes, fever for 3 or more days, abdominal pain, tingling in fingers and toes, and possibly dark urine. This is what you're educating your patients on. The rifampin can cause orange urine. Specifically, this drug alone can cause orange urine, saliva, or tears. It can make more people sensitive to the sun, so you're telling your patients to use sunscreen. It can also reduce the effectiveness of birth control, so you're educating your female patients in terms of using alternative methods of birth control if they are on rifampin. Precautions, you probably guessed, airborne. They're going to be in negative pressure rooms. Your patients are going to be in negative pressure rooms with the doors closed. Total gown, N95 mask, goggles, gloves, you name it. As a nurse, you are wearing everything to protect yourself and also protect your patient, okay? I know that the facilities at this point are not requiring N95 mask fittings, but if you are asked to take care of a patient that is suspected of having TB, make sure that you are fitted for an N95 mask and make sure that you wear it. Acutely, hand hygiene is always important, but it's even more imperative when you're taking care of these patients, and also educating the patients to make sure that they're covering their mouth and nose every time they cough, sneeze, or produce sputum. Make sure that they're putting their tissues in the trash or toilet, okay? And if you have a patient that is coming in and they suspect that they may have TB, they need to be placed on airborne isolation immediately until proven otherwise. As I said, the biggest thing here is to stress compliance, because if patients do not take their full dose of medication, the disease can come back. Until the sputum is negative, usually 2 weeks, patients should minimize time in close proximity with other people until they have been proven that they no longer have TB. And of course, anytime that we have TB in a patient, we are required to notify the public health department. How do we know if a patient is responding to our treatment? Well, what about their symptoms? What's happening with their symptoms? That's always important. But the most important is that the doctors are going to be conducting sputum cultures or other specimens to make sure that the TB has totally disappeared, so to speak. Specimens should be examined at least every month until the culture results have converted from positive to negative. And then, of course, the doctors may be ordering some chest x-rays to monitor the patient's response to the treatment. Okay? If you guys have any questions at all, please let me know. Otherwise, I will speak with you later. I will see you later. Thanks so much for your time. Take care. Bye.